Good morning, welcome to Regions EMS. Let me guess, you're looking for Bjorn. Well, he's around here somewhere, unless he went on a call. Would you like some coffee while you're waiting? Okay, well let me know if you change your mind.
Oh, hey. Oh, is it that time again already? All right, I think we got some topics here. Let me see what we can dig up for this month.
Hey, you bum. What are you doing? I'm like, get away from my... Get out of here. Jeez.
Look, you gotta stop following me. It's kind of creepy. I'm gonna go get some topics together for this month. You go, I don't know, just play an intro sequence or something. I'll be right back. Okay, we rolling? Hi, Dr. Peterson here with Regions EMS. It feels like we just did this 2 weeks ago, but here we are, February 2018. This month will be a bit of a grab bag of topics, hopefully something for everyone, so let's dive in. Last month, several of us had the opportunity to attend the NAEMSP annual conference, otherwise known as the National Association of EMS Physicians. This is a great annual conference that allows EMS leaders from around the world to come together and share cutting-edge research and ideas. And if 1,000 EMS medical directors in one room doesn't scare you, well, you should have your head examined. The parts of the conference that I look forward to each year are the poster sessions, where we get to mingle with other researchers and learn about the very latest in EMS advancements. Well, this year, we brought our video camera, and Dr. Haley was able to corner a few of the presenters to talk about some of the projects that we felt were either relevant to us or just plain interesting. So with that, here's what you need to know.
All right, Alex, can you tell us a little bit more about yourself and where you're from?
Sure. So my name is Alex Petrie, and I'm a medical student from Penn State Hershey in Pennsylvania.
Great. Alex, what kind of research did you do?
So I did research on intraosseous needle placement in the field by paramedics. So going to a regional conference and having paramedics show on a live model where they would place a IO needle in the field. We found that the location that people thought that they were supposed to place was actually pretty far off compared to what research says the placement should be, which could lead potentially to higher complications in the field and potentially show that there needs to be some kind of retraining in intraosseous needles, especially for people who don't use them as often.
So Brian, can you tell me a little bit about yourself and where you're from?
So I'm the training and credentialing officer for Cumberland County EMS in Fayetteville, North Carolina, and we're a fairly sizable EMS agency in rural North Carolina, about 65 to 70,000 calls a year.
So Brian, tell me a little bit about your research.
So we looked at some of the research out there about epi and the use in cardiac arrest, and there's some people talking about possibly being bad. There's a few studies that we looked at, and we looked at the studies and we decided that it was either none or all, so we decided to do something different. We actually just decided to try and do one epi in cardiac arrest and see if it made a difference. And we saw some sizable difference in the outcome of patients, not only sending them home, but also the ones that we sent home with a normal neurological function compared to what most of the other studies showed. But from the beginning, we've shown at least a 20 to 30% increase in the neurological stat, or 20 to 30% increase of patients that went home with a normal neurological status compared to before. So we're sending more people home. And of the ones that we send home, it's a much higher percentage that have a normal neurological status than what we comparatively sent home before.
Dr. Lula, can you introduce yourself, tell us where you're from, and a little bit about your research?
Sure. So I'm a second-year emergency medicine resident at Washington University in St. Louis. And I did my research project studying the rates of suicidality in EMS providers. We hypothesize and we suspect that given the high amounts of workplace stress that EMS providers face, that they are at risk for future suicidal behavior. And we kind of wanted to tap into this. We also know that having a history of suicidal thoughts increases your risk for committing suicide in the future. So we kind of wanted to research this and see if we could kind of identify the scope of the problem and see how it exists in EMS. So essentially we used a validated survey instrument called the SBQR, or the Suicidal Behavior Questionnaire Revised, which assesses several different dimensions of suicidality. And we administered it to a convenience sample of about 2,900 EMS providers in the greater St. Louis metro area. And then we tried to calculate these SBQR scores, which per the survey says that if you have a score greater than 7, that's associated with the risk of suicidal behavior in the future. And we tried to correlate this with other risk factors like, were people in fire-based EMS systems having higher SBQR scores, or people who had worked in EMS for 20 years, do they have higher higher SBQR scores? And we tried to identify any risk factors if we could. So kind of our data, I think, was pretty surprising and pretty alarming in terms of the magnitude of the problem. So essentially, we found that about 27% of paramedics or EMS providers said that they had suicidal thoughts in the past year. And when you compare that to the general population per the CDC data for suicidal thoughts in the last year, it's about 3.9%, so about 7 times higher with EMS personnel. And about 29.9%, about 30% of EMS providers had SBQR scores greater than 7, reflecting future suicidal behavior. So I thought those numbers were pretty alarming. We didn't identify any relationships with being in fire or being in a hospital-based EMS service, et cetera. We didn't identify any quote-unquote risk factors for having a higher SBQR score. But I think we were hopefully able to kind of expose that this is a major issue, and that hopefully it'll serve as some groundwork for some future research for other people who are interested in this topic.
All right, so Dr. Kroll, can you tell us a little bit about yourself and where you're from?
My name's Melissa Kroll. I'm a current fellow at the WashU program in St. Louis. And essentially this is my poster, my research that we've been working on. So essentially it's, can hand grip technique affect the volumes provided when doing a bag valve mask? And the background of this is, why did we look into this? What we looked into is, one, we know that the European Resuscitation Council recommends a volume of 500 cc's per breath. And we know from a previous study that we did that adult BVM provides approximately 800 to 1,000 cc's per breath by paramedics. And so in that same study, we found that a pediatric BVM provides a volume of approximately 500 to 600, which is a much more appropriate volume for any patient. And so what we did is we looked at 3 different hand grips. It's a 1 finger, a 2 finger, or a 3 finger, and just to see if that would change the volume. And we looked at the volumes provided in both adult and the pediatric BVM. And what we can see is that, yes, when you change the finger grip, you can affect the volume. These are all statistically significant, but what I tend to think is that these are not really physiologically significant. If you can still see, they're about 800 to about 750 cc's of volume per breath, whereas if you look at the pediatric, it's between 500 and 600 cc's per breath, which is, again, a much more appropriate volume. Our final recommendations are, we would recommend using a pediatric BVM if you're going to do BVM resuscitation, because it gives a more appropriate volume. But if you're going to use an adult BVM, use 1 finger squeeze, because it's the best it provides a slightly smaller volume, and that's really what we want to do, is we want to give the right volume to our patients.
Several months ago, we had the opportunity to meet up with Dr. Brent Myers, who was in town for an EMS conference sponsored by Allina. Brent is currently the president of the National Association of EMS Physicians, the Associate Chief Medical Officer for AMR, one of the largest EMS agencies in the nation, and the Chief Medical Officer for Evolution Health, an innovative healthcare delivery organization built around principles of community paramedicine. Needless to say, Dr. Myers is very well connected and definitely in tune with EMS policy and vision at a national level. We were fortunate enough to sit down with Brent along with Dr. Andrew Stevens from Allina Health to discuss performance metrics and why every EMS professional should care about them. Here's what you need to know. So we're here at the Allina EMS Pulse Check Conference today with Dr. Brent Myers, the president of the National Association of EMS Physicians, and Dr. Andrew Stevens, the associate medical director with Allina Medical Transportation. We're going to be talking a little bit about performance metrics and why they matter in EMS. And I think this is a good topic as we start to really analyze the data that you guys are collecting on patients and the treatments that you're performing and interventions. And we look at what makes a difference in patient care, what changes outcomes for the better, and what are we doing to advance EMS as a profession so that we can show that there's value in what we're doing for patients out in the streets. So Dr. Myers, first of all, let's start at a high level. What are performance metrics? What do we mean by that?
Yeah, so the key to the performance metric is that it's attainable by any provider. In other words, you can't have a metric that does not apply to the provider that's at hand. And too often in EMS, these have been hospital push-down type events, and people put them in hospitalese, if you will. They use a hospital language. So the first thing is they have to be things that are true to the EMS space, that are true to the experience of the EMS provider. The second piece of a good performance metric is that you can have a statistic around it. The last thing we want to do is create a metric so that if there's one mistake somewhere in the world, it creates a negative effect across the system. And the classic example is, let's say the performance measure was aspirin for chest pain, and you as the individual provider only saw 2 patients with chest pain, and you forgot aspirin once. Well, that's a 50% failure rate. So you have to build in the background, the statistical expertise and knowledge base such that that person does not get a negative outcome because of a single miss, even though by a percentage. So applied to the group and statistically relevant so that the measurement actually means something as opposed to just simply a number that's easy to generate.
So what's happening at a higher level in healthcare with performance metrics from the hospitals, clinics, the physician level patient care?
So in the other areas of healthcare, the evolution is now going to what I would call phase 2. So phase 1 of performance metrics was much more around a process. So if a patient came into the ED and they had chest pain, did they have an EKG within 10 minutes? Did somebody read it? Did they get an aspirin, et cetera? Very much process measures. We are now entering into the macro-MIPS age, which is where the actual performance of the physician as an individual as well as the group become much more relevant. So the measurements around that have to do with not only process, but ultimately outcome. And so simple things like, if we use the EMS analogy, how fast the ambulance arrived is not going to be sufficient much longer from the healthcare perspective. That is a process. What you really want to know is, how did my STEMI patient do? Did they leave the hospital without CHF? Did they have good functional outcome from a stroke, et cetera?
So our motto at my agency with Regions EMS is critical care begins in the streets, so that we truly believe that EMS is an extension of that hospital-based care. And yet up to this point, EMS hasn't been held to any standards. You know, we get the Medicare payments for BLS, ALS1, ALS2, and a lot of times there's really nothing behind that. It just depends on how many meds you give or how many procedures you do. And we're not looking at outcomes yet. So where do you think this is going in the next 5 to 10 years with EMS and some of these performance measures that are coming from the hospital but might be trickling down into EMS?
So the CMS language of this is what's referred to as a condition of participation. And so initially, the condition of participation for EMS was very low, moving very quickly, now in air, and then very soon to follow through a bill mainly sponsored by the AAA, the American Ambulance Association, that's looking at billing. Everyone understands that CMS is no longer going to pay simply for doing a thing. The condition of participation is going to be one must report on the quality and then ultimately the outcome of one's care. So we are seeing this in legislative vehicles that are proposed in Washington, D.C. today.
So if we ignore this, then our processes and our care is going to be dictated by other agencies that may not understand what we do.
That's exactly right. And this has been the push from NAEMSP, NAMT. Many of the large national groups have recognized that these conditions are coming, these quality measures are coming, and there's two choices. One, define them yourselves in a way that we all can understand and that make clinical relevant sense, or two, sit on the sidelines and wait on someone at CMS that may or may not have the relevant expertise to pick from their hospital bucket and try to make those fit in the EMS world.
So what's happening at a national level, once we decide what metrics we are going to measure for our agencies, that's fine, but at some point someone at a higher level has to make a decision for what the government or the payers are going to require of us. Who's making those decisions? What groups are out there that are advocating for us?
Sure. So the National Association of EMS Physicians, National Association of EMTs, and the AAA, American Ambulance Association, are probably the three largest in this particular space. There's a whole host of other agencies. NAEMSP, for example, the National Association of EMS State Officials, really does a good job of the baseline protocols, the quality metrics that one might propose within the industry. But to move it to the next level, it has to come through the payer side. Most of the payers follow CMS. So whatever Medicare says, in general, is what the Blue Cross Blue Shields and the Aetnas of the world are going to do. So right now, there is a bill that is sponsored by all of those organizations, but is led by the American Ambulance Association, that is moving the first step of these quality metrics into the federal statute. That has been on the Hill for a couple of years. It will eventually pass. Then what we'll see is probably a 24-month-ish time frame where all stakeholders will be invited to the table to say, these are the ones we've used, these are the ones we've used. They'll use some peer review stuff that's already out, but the Medicare and Medicaid services are very particular about talking to users in the street to make sure they're applicable. So there'll be an opportunity once we've crossed that first threshold in the near term to get that done. I would anticipate within the next 24 months we'll be sitting down, and 5 years hence there'll be at least one or two of these in play, if not multiple.
So this is very imminent for providers that are in the middle of their EMS career right now. This is going to happen at some point in their career.
I would be shocked if it doesn't, simply because if you look at the writing on the wall and say, where have they had trouble before, we're going to tie payment to quality so we know we're getting what we pay for, and then we're okay to pay for it, and they move forward.
So Dr. Stevens, why should this matter to our frontline providers, the medics and the EMTs that are out on the streets providing this care to patients?
Right, and it's why does this apply to me? Or what does it matter? I come to work, I do a good job. Why is Big Brother watching me? And I have a total different take on it. You know, Brent gives a great outlook on the future and why we need to do this as a nation. You know, we got to own our own profession here. But I'm just a simple guy. It's like you got to be accountable and you got to be disciplined. That's why I got good at my job. And we have to know how well we're doing at our job. It's not Big Brother watching you. It's the difference of, I live in the community that Align EMS serves. I want to know if I have to dial 911, how good it's going to be, the care that gets there. I'm not so worried about how fast it gets there, but are we going to do the right things? And I think that's the big piece for us, is look at those things that matter.
And the beauty of that is that's not a zero-sum game from the provider perspective. For me to succeed doesn't mean that someone else has to fail. Right. And that's the beauty of a good performance metric, is that this is attainable by anyone that's providing the care. And yes, it's fun to do the comparison, and that gets people moving, but it doesn't hold me back. Unlike some of the other CMS measures, for example, readmission penalties are all based on how your neighbor is performing. Right. These are 100% within the provider's control, which is nice.
Any other main points that you would like to communicate?
No, I think that the most important piece of the whole thing is there's a whole host of reasons that performance measures are coming out, right? We know that. There's payer reasons, there's condition of participation, but at the end of the day, it's why am I doing this work? And to me, it was far less satisfying to make sure I was using the air horn appropriately, not to have that 30-second delay. There's very little satisfaction over time with that approach. There's a lot more satisfaction over time to say, I've done this, this, and this, and it's contributed to the following outcome, and there's evidence that supports that. And so the patient actually did better because of what we did, as opposed to we met some arbitrary metric. And that takes some time. That's a conversion from checkbox, I'm done, to I do all these things and I've actually changed the outcome for a group of patients.
It's not just about running an operation and running a clinical service. It's all about getting to that end point like you talk about, where the care is just excellent so that you don't have to worry about what's coming in the future.
One of the phrases that I've used in a previous presentation is nobody should have to worry about who shows up when they call 911, right? You know, I mean, I live in the region's EMS service area,
Right.
a number of our agencies, and same thing. If I call 911 and it's my kid or my wife, you know, or friend, neighbor, I don't want to have to worry, you know, oh, I hope this guy isn't working today. You know, it shouldn't be that way. It should just be that we know what standard we are holding our providers to, and that we have measurements that show that that's being met.
We're really trying to push that. I like that mentality, and you have the same mentality. I know Brent does too, is to just push that ownership of, we own this profession, we own this service, we own the care. So let's make sure that we know how good we are about doing it.
So both of you, thanks for your time today. This has been a great discussion. Appreciate your insight and your wisdom and your national perspective, Brent, and then Andrew, obviously, as a partner locally. It's really good just to show that what we're doing here in the Twin Cities and in Western Wisconsin is along the lines of what's going on at a national level, and this is a movement that we can't ignore. We have to embrace it, otherwise we're going to be left behind and we're going to be caught playing catch up. So thanks for your time. We'll have more to come on some of our region's EMS performance metrics, so stay tuned. I think one of the key points from Dr. Myers is that there are already changes in place which will affect how we provide emergency medical services. Our profession will be better in the long run if we embrace this now and work to define those changes, rather than react when someone else tells us what to do. More to come on that, so stay tuned. Hey, if you haven't already, follow us on social media and leave a comment if you like something or have an idea for a future topic. We heard from a lot of you about last month's segment on human trafficking. We want these videos to be relevant, and a big part of that comes from your feedback. Well, time to get back to work. From all of us at Regions EMS, be smart, be safe, and be professional.
Oh.